All right, guys, welcome back. We're talking about deltoid tears, a large ligament that only in the last 10 years have we been spending more time discussing and understanding. Manuel Pelligrini out of Chile will be giving us, he'll be the moderator for the session. And we just can't get rid of Cristian Ortiz. He keeps showing up session to
Yeah.
session. Everybody wants you. All right. Well, our
Well,
sponsor for this session is Bioventus. I want to thank them. And Manuel, it's yours.
Thank you, Selene. Thank you for this opportunity. We're gonna spend this hour discussing about a very exciting topic as it is the deltoid tears. The first half we'll be spending some discussing about acute injuries, and I will leave Adam Schiff from Loyola to start the discussion. Adam,
great.
can
Thanks,
you please
Manuel.
start sharing your screen?
I will try to.
Got it.
All right, perfect. All right, thanks. So everyone, Adam Schiff from Loyola, and I was a Duke Fellow with Manuel. And so when we got assigned the topic of deltoid repairs, I thought this was easy. Manuel said, you give a time that you fix a deltoid, and the solution was very easy for me. It's always. As Manuel serves as our moderator, I figure I need to be careful, or he might come at me with a hammer. But so I pretty much always am fixing deltoid ligaments, at least especially as they relate to certain clinical conditions. So lateral malleolus fracture with a deltoid tear, I think by definition, that's how we would define an unstable ankle fracture. If the deltoid is not injured in an isolated lateral malleolus, it's probably stable and doesn't need surgery. So if the deltoid's involved, I believe that it should probably be repaired, and I do repair those. And syndesmosis injuries also get a deltoid repair, and those can be associated with or without a fracture. Obviously, the Mason-Neuve variant, where there's a higher fibular, proximal fibula fracture, almost always involves deltoid ligament or a medial malleolus fracture. And if the deltoid ligament is injured in those cases, I believe it should be fixed. And then there's isolated syndesmosis injuries, and I think one thing that separates a syndesmosis injury that's stable from an unstable syndesmosis is the involvement of the deltoid ligament. And so for these unstable syndesmotic injuries, when there's deltoid involvement, again, I think the deltoid should probably be repaired. And then there's the case of the chronically unstable or chronic instability medially, where the deltoid ligament should probably be fixed or repaired as well. And more importantly, it needs to be diagnosed. I think that's a very underdiagnosed injury. These typically happen in our athletes, and we all know Manuel from his football days, but he does have a history of American football, at least in basements. This is him playing for, I think the Washington Football Club. So medial instability with associated with lateral sprains. About 70% of lateral ankle sprains have some medial involvement, particularly by MRI. And obviously, most ankle sprains don't go on to gross instability and need surgical treatment, but there is definitely a subset that do. Probably about 5 to 10% of lateral ankle sprains ultimately will lead to someone with chronic instability. And many patients with chronic lateral instability also have medial instability. And this is particularly true in higher level athletes. And we don't typically know about this unless we look. In the United States, most people with lateral instability are getting MRIs because they're available everywhere, but that's not always the case globally. And it's certainly not the case with certain insurances limiting it. And this is definitely a rationale for doing arthroscopy, but a lot of patients with lateral instability have medial instability, and the deltoid needs to be repaired in those as well. While our lateral ligaments tend to heal much better non-operatively, you have isolated lateral sprains, medial ligaments tend not to heal as well non-operatively. And so I would always exercise caution in patients who have acute sprains that have a lot of medial sided injury also. That medial side would necessitate or lead you to think about a surgical treatment much faster than lateral instability, which almost always heals and goes on to essentially cure instability. So I want to spend a few minutes on the diagnosis because I think it's a difficult thing to do. The first would be pretty much a clinical examination, right? Do they hurt medially? But they pretty much need stress, at least in the office. And so for me, all these patients are getting a clinical external rotation stress test. It certainly helps to differentiate syndesmotic injuries, but it does tension and stress the deltoid ligament as well. And so for patients who have pain medially on a physical exam, it's at least getting you to think that they have a deltoid ligament injury. It's very difficult for these acute ones, though. Patients have pain and they might be guarding and might not allow for external rotation stress. So certainly, if there's medial sided tenderness, you need to keep a close eye on it, whether it's with a period of immobilization before an MRI or even an acute MRI. When patients have a lot of pain medially, it's either their deltoid ligament or typically an osteochondral lesion of the talus. And we need to pay attention to that, at least in consideration with a deltoid. Ultrasound is another modality that's very effective for diagnosing these injuries. It can be done in the office. If you're a good ultrasonographer, I'm not, and have our radiologists do it, but an ultrasound can diagnose deltoid ligament injuries quite well. You can see fluid traversing from the joint around the medial malleolus. And then another test could be an MRI. The advantage, of course, of an ultrasound to an MRI is that it can be done dynamically, and patients can have essentially a stress test done under ultrasound at the same time. And you can get a sense of, is the deltoid stable or unstable? Is there just fluid and edema in the ligament, or is there not? But again, it needs to be a good ultrasonographer for that to happen. MRI is also very useful for deltoid instability. And this is an example of one patient who had an isolated syndesmotic injury with a deltoid ligament injury as well. And you can see here that there is no essentially continuity of the deltoid. So superficial deltoid is this black strand over here, and you're starting to see some of it, but certainly there's no fibers that appear to be intact deeply. And on our, as we scroll through it even further, it's all just essentially torn, shredded fibers in here. And so that is pretty much characteristic of an MRI finding of a deltoid ligament tear. When they're stable, you'll see striations, you'll see the black lines, and in this case, it does not happen. So an MRI is very useful, with syndesmotic injuries and everything else. Stress radiographs can be useful as well. The challenge with these is that patients don't always want to open up on a stress. They're guarding, they're hurting, and so certainly in the operating room, or if you can give them an ankle block in the office, a stress radiograph can be very useful. And this would be an example of what one might look like. So this would be a normal, A would be just a normal fluoroscopic image of an ankle. And then when there's a lateral or external rotation stress applied to it, you can see it gap open medially, both the medial clear space and the superior clear space on the medial side open. And that's a sign of instability of that deltoid ligament as well. When that's acute, that pretty much needs, in my opinion, an operation and a repair as well. This is something that I've taken to do with patients with lateral instability at the time of their lateral stabilization. I think we get a good sense of whether the lateral ligaments are stable or not through a physical exam and through an anterior drawer test, but the deltoid might not be as reliable on our physical exams. So under fluoroscopic views, you can tell right away if the deltoid is stable or not. And if it's not stable, then this can be repaired surgically while the lateral ligaments are taken into account. And then lastly, I think probably what will become the gold standard for deltoid ligament tears, either acutely or with instability, would be an arthroscopy. And there's a few ways to evaluate the deltoid ligament arthroscopically. The first is, I think, the more classically described, and that would be the drive-through sign. So through your medial portal, basically trying to put the scope into the medial gutter. And if you can drive through that gutter where you see separation between the medial malleolus and the medial side of the talus, that instability would say the deltoid is not stable. You can often turn and look down at that view and see some remnant or some tearing of the deltoid ligament as well. But on the more chronic ones, it's full of scar tissue, and until you do a really thorough debridement, it's hard to visualize that. But the drive-through sign will tell instability very well. The other way arthroscopically, as you can see in this picture, would be looking from the anterolateral portal. And from that portal, if you can look basically into the medial gutter and see the posterior tibialis tendon, which is visualized here, that's a sign of a complete deltoid ligament rupture as well. This was taken from a paper that did this at the time of lateral malleolus fracture, so arthroscopy at the time of fractures. And through that anterolateral portal, you can see the posterior tibialis tendon. I don't think this is all that common, but potentially in the acute injuries, certainly in the chronic ones, there's a lot of scar and it's hard to see that. But if you see that posterior tibialis tendon clearly there's a complete rupture. The other thing that's worth pointing out, and I'm going to touch on our repair, is how close that posterior tibialis tendon really is to the medial malleolus. It is right there. And for deltoid ligament repairs or reconstructions, one must be careful to protect that posterior tibialis tendon. It can easily be transected or injured, and that sort of defeats the purpose of the repair to begin with. I know arthroscopy can put some people to sleep, but Manuel is an excellent arthroscopic evaluator, and he would never fall asleep during his scope. So I just want to touch base on deltoid ligament repairs and how I repair them. And so for me, it's an anterior medial incision. Again, I always cheat anterior on these. And so unlike a medial malleolus fracture, I'm very on the anterior side, almost into the medial gutter for a few reasons. Number one, there's a high association of medial osteochondral lesions of the talus with deltoid tears. And so I want to be able to get into the joint and see that. Typically, I'm doing an arthroscopic evaluation first. And so I would get a sense of the osteochondral lesion, but not always are these scopes. And so if it's not going to be a scope such as with a fracture, I don't typically do a scope at the same time. And so it should be treated anterior. The other thing the anterior incision allows is to save the posterior tibialis tendon. It is right behind the medial malleolus. It runs pretty far anterior as it traverses towards the navicular. And if that incision is just posterior or even straight onto the medial malleolus, you will see that tendon every time and it jumps out at you. So treating anterior will protect your posterior tibialis tendon. In almost all of these tears, it's an acute avulsion off the medial malleolus. It tears right off the medial mal, and you're able to sort of flip it out of the way and look into the joint. Obviously, superficial deltoid is superficial and extra-articular, but the deltoid ligament, at least the deep deltoid, it has intra-articular components to it, from the talus to the medial malleolus on both the anterior and posterior colliculus. And often in these acute tears, it can actually sort of get stuck in that medial gutter, and it needs to be taken out of the gutter. And once you can take it out of the gutter, it allows for a much better reduction, close the medial clear space. Prepare the medial malleolus by taking down cortical bone. It's a good, healthy, bleeding cancellous bone, and then I fix it with suture anchors. Tunnels are described as well, but again, the posterior tibialis tendon is there, and I like to be nowhere near that. This would be an example of one of our repairs, and so this was an acute injury with a syndesmotic injury, and so I scoped it first and confirmed that it was completely torn. And then this is the medial malleolus here. And this is the deltoid that has avulsed completely off. So I placed anchors. There's two of them, one back here, and there's one anterior you can't really see. And I run them through the deltoid in order to repair. And so that's our deltoid ligament repair that way. I always oversew it to the periosteum. I try to get both the deep and superficial components at the same time, or through different passes of suture to reduce both of those. I don't know if it's ever been associated with adult-acquired flat foot or progressive collapse in flat foot, but certainly superficial deltoid has components in all of those features. And I think leaving these alone or chronic instability could certainly lead to some of those developing down the road as well. Manuel, you will become a very successful man treating deltoid ligament ruptures. Here you had to find a random car on the street and pretend it was yours, but I'm sure in no time you will have your own soon. Thank you.
Thank you, Adam. That's a great presentation. Great pictures as well. Thank you. So we're gonna move forward. We are having Cristian Ortiz now discussing about when not to repair a deltoid ligament in ankle fractures. Cristian, all yours.
Okay, now you can, I guess you can hear me. Manuel, can you hear me? Can you see my screen? Are you able to see my screen? Yeah, okay.
I do see your screen and I can hear you. Yes.
Okay, I guess you caught me a little bit sleepy when you asked me about this, because I said yes, but I never figured out that you were going to ask me about a talk related to non-operation of the deltoid. But okay, it's more fun. Anyhow, this case I'm going to show you is in the scenario of an ankle fracture, and you guys, Adam and Manuel, you were trained at Duke, and you're well aware of what Manley thinks about this, and he's absolutely sure that in an ankle fracture with a syndesmotic injury, if you repair the deltoid, your syndesmosis does not need any repair at all. That's one of the scenarios that you may face. And I typically argue with Jim about this, and I say, okay, the anchor looks very strong. I agree with that. But how about the sutures? And Adam just showed us a nice picture showing his repair. But occasionally I have some doubts about my suture, if it is going to be strong enough. And that's why I typically stress my syndesmosis after performing something like this. And I typically end up adding some flexible fixation to the syndesmosis. So I have my doubts about just repairing the deltoid. Let me show you a diagnostic case. This is a very simple case with an ankle fracture that on weight bearing, this in Spanish here, it says, Manuel knows about this, is weight bearing X-ray. And if you take a closer look at this fracture, I guess most of us would initially think about the conservative treatment. And of course, this guy had some minor injury and minor pain on the medial side. So as Adam explained very carefully before, and very clear, I think, pain on the medial side does not necessarily mean that your deltoid is completely torn. So initially we saw this case and we offered conservative treatment, but he came back a week later with increasing pain and feeling worse. And this case was treated more than 7 or 8 years ago. So he came back with more pain, and we didn't have a weight-bearing CT available at that moment. So we said, hey, how about performing something that is well described in literature, which is the stress lateral view. And this is a modification published in 2019 by one of our Chilean friends. And this AP view is pretty easy to take, because you just send the patient to the X-ray department. You do not need to be there. You do not need a block. And with this Chilean modification, the patient doesn't even need to get off the wheelchair. You just send the patient just like he came to the office. And after taking the X-rays, we assume that the deltoid was completely torn, and that patient needed surgery. So after treating this patient like this, we came back and saw a few more cases like this. And one patient asked me back, doctor, I understand what you're explaining to me. If my ankle is unstable like this, if it heals like this, my ankle is going to go into arthritis, and it's going to, I'm going to have pain forever. But you're not considering that I do not walk like this. I walk like this. And if you take a look at my X-rays walking like this, there's no change in the weight-bearing area of the ankle whatsoever. He was an engineer, and very smart one. So I said, well, I think you may be right. You will not walk like this. You will walk like this. That patient didn't have any pain at all. And he was walking without crutches 2 weeks after the injury. He had mild pain on the medial side. And his ankle, I don't have that picture, but it was pretty similar to this one. So that in that moment, I was not lucky enough to work with Manuel to give me his advice, but my older partners, my my previous partners, they were as smart as Manuel, and they said, why don't we take x-rays from the contralateral side? And guess what? The other side was just like this one. And that's not something so weird, because we have seen, and we already know from testing many chronic lateral ankle instabilities, that there's no way you can predict an ankle instability just from taking stress x-rays. It's much more complicated. So you can see an ankle looks like this, and it's completely asymptomatic and complaining about a hammer toe, for instance. And so you cannot trust any stress test on its own. You need to consider the whole picture. You cannot trust one single X-ray, ultrasound, MRI on its own. You need to take everything into consideration. And if you have some doubts, of course, I fully agree with Adam, you need to add a drive-through sign. Like in this case, I'm putting a 4.0 scope easily into the medial gutter. And if you go all the way down, looking for the very distal tip of the medial malleolus, you're going to see that the distal malleolus is denudated, at least from every single superficial deltoid fiber, and you can hardly see some deep fibers back there. So if you put everything together, you may come with a conclusion that the deltoid is completely torn, but that not necessarily mean that you need to operate the deltoid. All you need to achieve, and please don't forget the goal, you need to recover normal anatomy, normal loads on your ankle to prevent arthritis and pain over time. You're not treating x-rays, you're not treating scopes, you're not treating anything, you're treating a patient with everything involved. This is a case we operated like 10 years ago. We didn't have in mind the posterior malleolus like we have it right now. And we look at all the images, and we were careful enough to pay at least some attention to the posterior malleolus. So we put some screws from posterior to anterior, and we thought we were perfect. But guess what? 3 weeks after surgery, it collapsed. And I ask you back, did this patient collapse because we did not repair the deltoid? Did it collapse because we did not repair the syndesmosis? Or it basically collapsed because we didn't take into consideration the posterior malleolus? And my answer at this point would be that in most cases in which you have a posterior malleolus, you need to address the lateral fibula, the posterior malleolus, and after that has been done, then you go back to the syndesmosis. Most of the time, the syndesmosis will not need anything else. In this case, to be honest, I don't really remember why we added the syndesmotic screw. I guess we just were afraid of a recurrency. But in most cases, after you reduce and fix properly the posterior malleolus, you don't even need, of course, syndesmotic screws, because the posterior malleolus has most of the attachments of the ligaments of the syndesmosis, and the same thing happens with the deltoid. Then we test the deltoid, but don't be afraid of testing the deltoid and comparing with the other side, because the medial side normally opens up a little bit. So I'm bringing up this case to you to give you something to think, and not just looking at the deltoid that on a stress test opens up and you immediately need to go for repair or surgery. That's why I brought up this case that Manuel asked me to bring, and I have some others in which the deltoid was not repaired because we just repaired the rest. At the beginning, we tried to repair every posterior malleolus in our most comfortable position, but then we realized that it's much easier just to put your patient on prone position, and in most cases with a posterolateral approach, as these images show, it's very easy to get a free access to the posterior fibula and the posterior malleolus, and once you reduce that, most of the rest of the ligaments come into place, and you don't need to address the syndesmosis separately or the deltoid. And just to remind you, I've been in this conference, just my third participation. No, our IFOS meeting that will be held face-to-face from the 28th to the 38th of April next month in Chile. Thank you, Manuel, for the opportunity and inviting me to this.
Thank you, Cristian. This is a well comprehensive review about the acute injuries. Now we're going to ask Tim Daniels to we are going to move to the chronic ruptures. Tim, all yours.
Thank you, Manuel. Okay, I've got no conflict of interest for this talk. So the deltoid ligament is a fan-shaped ligament. It's one of the larger ligaments in the body. It's got a deep component which attaches to the talus. There's an anterior and posterior. And believe me, this is a preliminary talk about the anatomy of the deltoid. It actually could be broken down into 8 different layers. But we have the deep, which basically help to prevent external rotation and pronation of the talus within the ankle mortise. And then we have the superficial portions of the deltoid, the tibial navicular and the tibial calcaneal, which are very important in preventing talar abduction. Now, I'd like to point out that the tibial calcaneal and the tibial talar portion of the deltoid ligament, I'm not sure if you can see my arrow, but this is the primary stabilizer on the medial side. This is equivalent to the calcaneal fibular ligament on the lateral side. So my bias is that if you're going to repair the deltoid, you need to, number one, make sure that you're reconstructing this tibial calcaneal ligament. And if you look for it, you will see it. It literally looks like the CFL. And then you should also be reconstructing the anterior aspect of the deltoid, which prevents abduction of that talus. So in essence, the deltoid prevents excessive plantar flexion, external rotation, and pronation of the talus within the ankle mortise. Now, those are great x-rays that Cristian showed, but when you develop an acute deltoid injury without the lateral side injured, so for example, in this cadaveric study on normal ankles where they completely transected the deltoid and then put a valgus stress, they could only open the joint approximately 3.7 millimeters, which is really nothing. I mean, if you cut the lateral ligaments, you'd be able to open the lateral side by 20, maybe 30 degrees, but it's not the case with the deltoid. So clinically, this is a difficult diagnosis. This patient has no deltoid ligament. I'm putting a valgus stress on that ankle, and you can see when I do a varus stress, there's lateral instability, but look at that shelf of bone that's developed on the talus and is actually helping to block further abduction of that talus within the ankle mortise. Now, this guy is one of the patients where we scoped and you could see the posterior tibial tendon. This patient has an isolated deltoid injury. Look at the instability that she's displaying. There's no increased forefoot abduction when she internally rotates her tibia. What happens is that she collapses through the ankle joint. I'm just going to show this again because you have to look for this carefully. When they internally rotate, they collapse. You can visualize that talus going into some degree of valgus, but more specifically external rotation when they perform these tests. And this is her just doing it in a more exaggerated way. Here it is from the front, and pay attention to the lack of forefoot abduction. This is not a flat foot. Look at the increased creasing that develops laterally when she internally rotates. There's excessive amount of rotation in that ankle mortise. This patient has isolated deltoid insufficiency. Now she's able to do a double and single limb heel raise normally. And this is one of the characteristics of a patient that has a valgus hindfoot, but only deltoid instability. If you get them to do a single limb heel raise, their hindfoot will invert normally. They can go up on their toes. We learned so much from our patients, and this is a patient that I learned a lot from. She came in, she was a volleyball player. She was 27 years of age, had this high fibular fracture, and was complaining of ankle instability. You can see that the talar head is more exposed on the AP view of her right ankle versus the left. She's got this deformity, a banana-shaped deformity, at the fibula where the fracture occurred. This is the AP of her ankle. And once again, there's a subtle rotational difference. You can see there's increased gapping on the lateral side, and you can see more of the talar head on her right side than on the left. Now, these are her stress views, and I missed this. I mean, I focused on her lateral instability. This was her medial stress view. I thought it was relatively normal, but look at the gapping between that lateral talar process and the medial malleolus. I should have picked up on that and understood that was indicative of deltoid instability. Now, on the varus stress, there is no problem at all. I mean, she was obviously unstable. So what do you do in these situations? Does she need a fibular osteotomy? Should the syndesmosis ligaments be repaired? Lateral ligaments reconstruction for sure, but what about the deltoid? Well, this was early on in my career, and I have to say to the audience, what really got me interested in the deltoid ligament is that gradually as my practice moved towards end-stage arthritis and managing hindfoot deformity, I was inundated with patients that had a past history of ankle instability. They had a lateral ligament reconstruction. They did well for many years and then returned with obvious valgus tilt of their talus, end-stage arthritis of their ankle. Their deltoid had been unstable for many, many years, but their symptoms were relatively mild. Do you add a calcaneal osteotomy here? Well, you know, I did osteotomize the fibula because I thought that it was sort of a banana shaped and not anatomically reduced into the syndesmosis. I did have a CT scan to show that. I did a syndesmotic stabilization. I reefed up her lateral ligaments in an anatomic way, but I did nothing on the medial side. And these are her x-rays post-op. Now here's her clinical picture. Look at the creasing that she develops on the sinus tarsi area of her ankle. That can only be seen if there's excessive rotation of that talus or the tibia, whichever you choose. In this case, it would be the tibia because she's in a closed kinetic chain. There she's doing her normal side, and you don't see that creasing. There is stability in the rotational plane. And this is one reason why deltoid ligament instability is difficult to diagnose, because it is a transverse plane deform instability. It's a rotational instability. Now, the reason I show this case is she did great for a year. She went back to playing volleyball, and she came back at 2 years and said, you know, there's something not quite right with my ankle. I can't tell you what, but it just doesn't feel like the other side. And sure enough, she had now isolated deltoid instability. So I talked to her about the fact that, you know, we could repair the deltoid, that the reconstructions for the deltoid weren't ideal. It would be another 6 months of rehab, and she didn't go for the operation. In other words, she knew there was something wrong with her ankle, but she was functional. She was not turning over on her ankle every time she jumped up to spike the ball, and she was okay. But I can almost guarantee you that 3 or 5 decades from now, she will be a patient that returns to a clinic like mine with end-stage arthritis of their ankle, maybe a valgus tilt to the talus, and a gradual collapse of their medial arch. They develop instability in a manner that I don't think we fully understand yet. So you know, if do you have to repair the deltoid in acute injury? If the deltoid is injured and you maintain that talus against the medial malleolus during the critical phase of ligament repair, it's very possible that we don't have to repair all the deltoids that are torn. I at this point would get a deltoid repair if I had a ankle fracture that was associated with a torn deltoid, but that's my own personal opinion based on many pathologies that I've managed over the years. So this is a patient, you can see they've got valgus deformity of their talus, but look at the compensation through the subtalar joint. They do not have a stage 4 flat foot. This is a patient with chronic deltoid instability. This is the repair that I like to use. It is a what I call all around the world ligament reconstruction. If I'm repairing a deltoid, I'm assuming it's multi-directional instability. So I've done a medial incision. I'm very careful with the tendons here. We've isolated out the FHL tendon. We're pulling it up forward with the posterior tibial tendon. The reason that we've taken the FHL forward is because we're finding the sustentaculum tali, and then I'm going to do a drill hole just underneath the sustentaculum to recreate the tibial calcaneal portion of the deltoid ligament, the CF, what I like to call the CF of the medial side. Now you can see that she's had a lateral incision already. Somebody's repaired her syndesmosis, but it didn't help. I'm doing a lateral incision now. I'm taking the anterior talofibular ligament off the fibula. If you do a arthrotomy in the superior aspect of the ankle joint and stick something like a Holman or something smooth down the ankle, lateral aspect of the talus, you know that everything between you and that instrument is the anterior talofibular ligament. And I'm preparing the fibula. Now I use a VY graft. I use either an Achilles tendon or posterior tibial tendon, and I take it to the back table and I create a VY. There's my VY graft there. I'm creating my tunnel in the median malleolus. I try to keep this portion of the graft relatively thin so it's not too bulky. And I'm very careful with my proximal. I don't show it here, but I'll actually put a screw in and tie the proximal aspect of that tendon and then put an interference screw in. Now what I'm doing is I'm creating a drill hole just below the sustentaculum tali, and I'm coming out at the origin of the calcaneofibular ligament. So I'm bringing this graft through so that it exits on the other side, and you can see the hole there where the calcaneofibular ligament origin is. So there's my graft to reconstruct the calcaneofibular ligament. Now I'm drilling a hole for the calcaneofibular ligament. I only drill one hole, and the anterior talofibular I do just by sewing it to the surrounding tissues. I've also created a hole in the talar neck. So I pulled both of these grafts very tight through the talus, reefed up the medial side, and now I'm doing a basic ligament reconstruction with allograft on the lateral side, in both the calcaneofibular and the anterior talofibular ligament. So this is not an easy operation. I mean, I've done this surgery maybe about 50 times, and every time it takes me 3+ hours. It's a lot of work, but these patients are rock solid. They are stable afterwards and extremely happy. So, you know, I can't fully answer to the audience when to repair the deltoid ligament and when not to repair it. But what I can say with confidence is you can't ignore it. You need to take into consideration the deltoid ligament. And if it looks like it needs to be repaired, then repair it. Thank you, Manuel.
Thanks, Tim. That's a great talk. It's a tough topic. I would like to share a case with you guys. Let me see. Tim, can you stop sharing your screen?
Oh, yes, I can. Thank you.
There you go. So let me see. Okay, so this is a case of a 38-year-old male. He's a healthy guy. He plays soccer in a competitive team every weekend. He trains during the week. He's not a professional, but he's a sports guy. He complains about spraining his ankle, his left ankle, about 10 years ago. He's now having medial ankle pain. He has swelling when he's performing at his soccer team, and he has giving way. He failed non-operative treatment. These are his X-rays. So, Adam, what do you think about these X-rays from this patient?
Yeah, there's definitely something medially going on. It looks like an avulsion of the medial malleolus. It is a little bit of a bigger piece than you would suspect for just a regular old avulsion fracture. So I would be concerned that he has a deltoid ligament tear, if not something more substantial, also like a posterior tib tendon rupture.
Mm-hmm. So we have more X-rays here. These are his feet, and this is the lateral view, Adam. With this information, what do you think? Do you need more tests? Do you have? Are you clear on what is going on here?
Well, it is interesting on the AP of his foot. He definitely on the left side has a more abduction than his other. And I don't know if that's acute or not, but it certainly looks like it would be concerning. I would get an MRI of this to look at it more closely.
Yeah. So the only relevant sprain that he had was 10 years ago. So, Tim, what do you think about this?
Yeah, well, I've seen a number of these patients with a large avulsion fracture off the medial malleolus. And in fact, I've got a series of 6 patients where we've done ankle joint replacements on them and actually taken that fragment back and reinserted them to the medial malleolus. They've healed successfully, and that's been enough to stabilize the medial side. So I think this is a classic medial instability. I think that the deltoid is the primary instigator of the instability. It's possible the tear has propagated into the spring ligament. It's hard to say, but in this case, I would counsel him on repairing that large fragment, doing a open reduction internal fixation of the large fragment, maybe a suture anchor, and further augment the deltoid. And then I'd look at the lateral side as well. This guy's already got some arthritic changes, and if you look at his lateral standing view, he's got more anterior translation of that talus than on the opposite side. He's got it slightly anteriorly translated on both sides, but the left is more so than the right by maybe 5 millimeters. So, and I've often said that if there's any sagittal instability of the talus on standing X-rays, it's deltoid insufficiency until proven otherwise. So I would offer him a ligament reconstruction. I am a little worried about the health of his ankle joint, and I'd want to make sure that his ankle and subtalar joint were not already showing signs of degeneration.
Tim, somebody's asking if you still use the posterior tib tendon to do your deltoid reconstructions.
I use the posterior tibial tendon only if I am performing a talonavicular fusion. And in these cases, these are end stage cases. They've got talonavicular arthritis, they've got valgus talus and ankle arthritis. And the post-tib tendon acts as a really good reconstructive tissue for the deltoid, because you transect it proximally just above the medial malleolus, so you get about 6 to 7 millimeters of length. You split it into 2. It's got a very broad insertion site distally, and I find it works better than any tendon graft or drill holes that you can perform. But you have to be fusing the talonavicular joint. You can't sacrifice the post-tib tendon if that's not part of the treatment.
Nice.
Cristian, any thoughts about the difference that Adam noticed about the forefoot abduction on the left side in comparison with the right side? Will you take that into consideration in your planning?
You're on mute, Cristian.
Or Tim? Cristian?
Yeah, this is precisely the case that Tim was mentioning before. If you can get a deltoid injury or a medial injury to heal in the anatomical position, you're achieving the goal. If you cannot achieve an anatomical position of your foot and your ankle, you need to repair and do something, hopefully acutely. Otherwise, when you're dealing with a chronic injury, as Tim said, even from the technical point of view of repairing ligament, reconstructing the ligament, then it's much harder and morbidity is higher. And I don't know if I agree fully with what Tim said, because in the literature, oftenly you see some recurrences when you just treat the ligaments. So going back to answer your question, Manuel, when I see some malalignments or in the bones, most of the time, I tend to think about bony reconstruction and not just ligament reconstruction, because I'm a little bit afraid that, at least in my hands, results may not be so good. Maybe I'm doing something wrong. Maybe I'm missing something, but just soft tissue reconstructions, but when the bones are not in perfect alignment, doesn't work well for me. I need to add something else.
Good. So this is a fancy study. We have a weight-bearing CT scan for this patient. And the thing that what I wanted to point out is that look at, and as I mentioned before, this patient had an injury about 10 years ago. And then he started developing this problem that was chronically increasing his symptoms. And you can tell that there is some kind of instability of the medial column. You can tell there in the weight-bearing CT scan that you have multiple sags in the talar first metatarsal angle. So that tells me that there's more instability. And as Tim wisely pointed out, I do believe that the medial instability in this case also has instability of the spring ligament. So, Adam, does this weight-bearing CT scan changes what you think about this patient or not?
Yeah, absolutely. I mean, I think there's clearly medial soft tissue injury, but there's no doubt that the bone is involved at this point. And so, as Cristian said, I would definitely do soft tissue repair, but I would back it up with some bony, osteotomies, either a medial spacing calcaneal osteotomy or a lateral column lengthening, also to try to restore that.
Manuel, can I just add that the progression, chronic deltoid instability, the progression of it, I believe is very similar to chronic post-hip tendon dysfunction. You start with an initial event of instability of the ligament, and because of the increased rotational forces on that side of the hindfoot, you gradually develop insufficiency of all the other supporting structures. And you can see in this case, he's gradually collapsing through the navicular cuneiform joint, probably because he's stretching out his long and short plantar ligaments, as well as the spring ligament. So it's a cascading events that evolve over years, a cascade of events that evolves over years. We just haven't really clearly defined, in what order do these tissues attenuate when they are subjected to these excessive rotational forces every time the patient puts weight through the foot.
So, Tim, I think you're absolutely right, and I don't think it's well understood. But on ankle fractures with deltoid instability, historically, we've only been fixing the lateral malleolus. Do you think not fixing or not addressing the deltoid at that time will lead to that cascade over time, or do you think it's much more repetitive injury or malalignment, like in a collapsing flat foot?
Adam, I wish I could answer that question. I can't, because we really don't know the natural history of deltoid instability. All I can say is that I would say in a vast majority of ankle fractures, the deltoid scars up in a reasonable position, and it's not an issue. What percentage have an elongated deltoid once they've healed their fracture and begin to really stress the foot? We don't really know. All that we do know is a certain percentage do develop that problem, and they present to us at a later stage with hindfoot collapse and the beginnings of ankle arthritis.
So can I ask a question from one of the attendees? They're asking, when you're doing a double or triple fusion for flat foot stage 3, are you guys always doing a deltoid reconstruction then?
Yes.
Cristian, you?
I used not to do it, but now I think about it.
Okay. And Adam?
No, I'm not. I agree with Cristian. I've been thinking about it more and more, but I think once you fix that or stabilize that hindfoot, you're hopefully minimizing that risk that's going to keep falling. You're offloading the deltoid by doing that fusion. And so if they haven't started to collapse yet, I'm not sure that they're going to once you stabilize them.
I would just ask, that people consider imbricating the superficial part of the deltoid. It's a very simple thing to do. You just have to lengthen the incision about another 2-3 centimeters. It's got minimal morbidity, and if it manages part of the pathology, why not? You don't have to do and again, I could be wrong, but in my practice, I don't do like a 1 hour deltoid reconstruction. I just add an extra 10-15 minutes to the case and tighten up the superficial arm of that deltoid while I'm doing the rest of the flat foot.
But if you reduce the tenonavicular joint and have it reasonably well lined out, I mean, that essentially is shortening the superficial deltoid, isn't it?
You're shortening it, but if it's attenuated, it just sort of accordions. It doesn't really tighten up. So really all you need is to add a few sutures just to tighten it up a bit. I've been doing this for probably 12 years, and I have yet to see a patient come back where, I say, damn it, I over tightened that deltoid. I just haven't seen it. Maybe it's seen me, but I haven't seen it.
So, well, I think these are tough cases. So, and if you see here in the weight-bearing CT scan, you can tell how it's impinging on the lateral side as well. So, it's definitely. I think that that this case summarized, as you were saying, Tim, probably what happens when you have a chronic injury on the medial side and it start progressing and collapsing the whole foot. So in these cases, will you still just fix the medial? Because I believe that this guy, what he had was a fracture of the medial side. When he said that he had a sprain 10 years ago, I believe he had a fracture of the medial side, was never fixed. And this guy continue to play and do all his sports and start developing this. So do you have any cut point to decide, okay, I'm gonna just fix this guy, or when will you add an osteotomy to support what you were doing on your medial side?
This is a great case, Manuel, because you can see he's starting to develop a ball and socket ankle, which you see in these cases, especially if they've had this problem since teenage or early 20s. And so first of all, I would throw the kitchen sink at this guy, and I wouldn't hesitate to do a medial translation osteotomy of the calcaneus. Their morbidity is low, but very importantly, you have to warn this patient that this may be just stage 1 of a stage 2 reconstruction. Because I've seen a number of these patients where they've got early ankle arthritis, you deal with the instability in the flat foot, and they develop pretty rapidly progressive ankle arthritis within about a year or 3 years. Some of them actually get a chondrolysis. I don't know if it's the increased pressure on the cartilage, which has been subjected to excessive rotational forces and point loading. I really don't know. But for every patient I do this surgery on, I always tell them that their ankles got arthritis. It could progress quite rapidly, and it's possible that within a short time we're talking about dealing with the ankle arthritis.
Well, actually, I also got an MRI for this guy. And what we saw is that. This is another question that I have for the panel. So, when you have these cases with these pieces of bone, what do you think about the remaining tissue? So do you think that you can peel that bone off and just reattach the deltoid and it will work? Or will you just move forwards and choose an allograft, as you were saying? Well, we know what Tim is going to say, but Cristian, for instance.
I would be very careful about trusting just fixing the bone or reattaching the ligament. As I said before, I would go for surgery, prepare for everything. So I would take an allograft and I would take a look at the remaining tissues, and I would make my final decision during surgery, and I would try to keep it as simple as possible. If during surgery I get the impression that just fixing the medial malleolus will solve the problem, I would do that. I would like to do that if I feel it's going to help.
Adam, any thoughts?
Yeah, I'm not big on allograft reconstructions of deltoid. I just don't think they're that reliable. I don't think the soft tissue is enough to do alone, but I think if you're backing it up with osteotomies and I would probably add a lateral column lengthening to this. I think the soft tissue repair would, or the fixing the analysis would work fairly well.
Well, this is what we did. Actually, we went ahead and do this lateral column lengthening, and then did the medial displacement called osteotomy. And then what I did is that I peel off that bone. It was dead bone, wasn't that good, but we thought that the tissue wasn't that bad, so that we decided to reattach the deltoid there, and we just use a fiber tape to augment our reconstruction. And this is the follow-up at 6 months, and the weight bearing CT scan. 1 year follow-up showing how the subfibular impingement is not there anymore. So,
And
any thoughts?
as Tim
That's a great
predicted,
case,
the ankle is getting worse.
Yeah.
Yes. So actually, what Tim pointed it out. So the anterior part, you can tell there how the arthritis is developing. It's just there. It's a matter of time. But at least I believe we got a stable ankle and with a reasonable alignment for a young patient.
Yeah, Manuel, that if they've got any degenerative signs in their ankle, I unless they've got no deltoid, like occasionally you go in and the deltoid ligament looks like wet Kleenex, I do not use an allograft in these circumstances. Usually you got a very thick amorphous deltoid ligament that actually works quite well too, because I really feel these are staged procedures. When they reach this stage at 55 years of age, the natural history is set, and all you're doing is really staging their eventual ankle fusion or replacement.
In cases that you need to do something to the spring ligament, what is your treatment of choice, Tim? What do you do?
Oh, I mean, you probably won't like this answer, but if they're over 50, I fuse the talonavicular joint. I've got so frustrated with the spring ligament soft tissue reconstructions, and I know that there's some people that would disagree with me, and I respect that 100%. I'm just talking about my own frustrations. I do a talonavicular fusion, and their foot's stable and their pain's gone immediately. If I try to reconstruct that spring ligament, I think it's like a grade 4 rotator cuff tear. And then the patients where it has worked, they almost have no talonavicular motion at the end of it all anyway. So I've stopped trying to reconstruct the spring ligament unless it's in a young patient.
Adam, what's your choice?
No, I would try more of a reconstruction or repair, but I would alter it with, lateral column lengthening and a medial displacing calcaneal osteotomy. I've not been happy with talonavicular fusions, at least in isolation, and I've certainly revised a lot of isolated talonavicular fusions in Chicago into, add a subtalar joint arthrodesis also. So I would try to avoid talonavicular fusions as much as possible.
Manuel, just to clarify, I'm talking about people at the 55 year range, like this guy. For the younger patient, I agree with Adam.
Cristian?
Agree. I do like what Victor Valderrabano says, trust the bones. And that's even more true the older the patient you're treating is. As you move younger, of course, I guess we will all reconstruct. So, but the limit, I have no idea where the limit is.
All right. Guys, that's an awesome session on deltoid. Fantastic. Manuel, great job. And thanks all of you guys for lending your expertise. We are going to come back in a minute. I want to thank Bioventus for sponsoring that past hour. Thanks.
Thanks, Manuel. Thanks, Selene.
Thanks, Manuel.
Nice to see you guys. Nice to see you, Cristian.